Hi, everyone. Thank you for coming today. I am going to work on sharing my screen with you. Um, so, today, I really want to talk a bit about mental and behavioral health. My frame is really going to be that of patients, significant others, and even couples. Just a little bit about financial disclosures. I'm not receiving any compensation for any of what I'm saying today. I don't have any investments in companies related to pharma for prostate cancer treatment, etc. So I'm going to give you a brief overview about prostate cancer epidemiology, risk factors, a little bit about disparities before I go into the mental and behavioral health broadly defined, and then some information about lessons learned, future research and practice areas, and challenges, and then just a little bit, just a brief slide, and I can speak more about general cancer and prostate cancer specific resources. Okay, so prostate cancer remains the most commonly diagnosed male cancer in the U.S., and it accounts for about 27% of all male cancers. It's also the second leading cause of death. Accounting for about 11% of the deaths anticipated in 2022. This represents a decrease in cancer deaths and likely due to treatment advances, early detection, and so on. The risk factors, as I'm sure have been discussed in previous summit sessions, particularly revolve around African ancestry, family health history, if you've got BRCA1 or 2, or Lynch syndrome, and then modifiable, so factors that you can change, such as your smoking status, your overweight, obesity, etc. There are persistent racial and ethnic and socioeconomic status related disparities when it comes to prostate. U.S. and Caribbean Black men have the highest incidence, the number of new cases globally. And within the U.S., non-Hispanic Black and African American men have 73% higher numbers of cases than their white race or other race or ethnicity counterparts. Part of what's driving that earlier age of diagnosis, significantly elevated PSA levels, higher rates of advanced disease at time of diagnosis. This is really a problem, and we talk about it in the literature, but I want to underscore that as we go through this presentation. In terms of socioeconomic status and geographic location, your zip code in a lot of ways matters more than your genetic code in terms of cancer disparities, and particularly prostate cancer. We know medically underserved areas with low community resources have worse overall survival rates. And they're even worse if you're Black or African American or even Hispanic. I love this quote from an article by Chambers. Men are surviving longer with prostate cancer. They may not be surviving well. In addition to the disease-related effects, and my colleagues will certainly talk about this during later in this panel. In addition to the disease-related effects, there's persistent treatment-related effects. And along with those come psychosocial challenges. All of these unmet educational, self-management, psychological, practical concerns. Some of the studies that I located in the literature say that 30 to 50% of men diagnosed with prostate cancer will have unmet needs. 30 to 40% will have chronic distress and other mental health disorders or symptomology, and decreased quality of life. About 10% of cases will have suicidal thoughts. And there's also recent evidence from the pandemic that there's greater risk of complications and death rates from COVID-19. And this particularly hits our minoritized communities very hard during the last few years of the pandemic. So when we talk about mental health across the prostate cancer continuum, most of us are used to seeing this type of information where you've got this continuum from screening to localized disease to advanced disease, this continuum from screening through diagnosis, treatment, surveillance, and then ultimately end of life. And some of that manifests over time and in terms of various treatments at various phases of this continuum. What we're not great at talking about or thinking about is actually this issue of how all of these altered physical form and function pieces, the painful ejaculation, the retrograde ejaculation, penile shrinkage, painful receptive anal intercourse, urinary bowel leakage, all of these things that are very physical and can be addressed medically, then may impact this concept of mental health, where you've got an individual, a gentleman who's been diagnosed with prostate cancer, all of what makes this man who he is, from his family of origin to his religion to the work that he does to his encounters with friends and neighbors and coworkers. And we don't really talk about how we build supportive care around these gentlemen.
Hello, Dr. Goltz.
Yes, can you hear
Can
me?
you put your slides on slideshow
Oh,
view? There we go.
absolutely.
Thank you.
There we go. Sorry about that. Nerves, y'all. So we don't really talk a lot about how this human being, this man who is now coming into healthcare systems and their families, their partners, then have to navigate these medical systems that may not be well integrated with what we call supportive care or psychosocial oncology. So we know that there is a tremendous impact on health-related quality of life across the prostate cancer continuum, especially when we are talking about issues of masculinity, body image, and self-esteem. All of these things are related. You know, this topic of masculinity, how men are supposed to deal with something, an issue, in this case, prostate cancer. All of the normative roles and responsibilities that men have in this society, and how prostate cancer disrupts a sense of their identity, their self-esteem, their body image, their sense of control, their understanding about how the world works, or at least how it previously worked, running headlong into, and I know this sounds maybe strange to you, but there is a stigma around cancer that remains. And there are, there are myths and misconceptions about what having cancer or what prostate cancer may mean for the man. So they may internalize these myths or misconceptions and begin to believe they're not men or not whole men. They begin to grieve their loss of themselves as previously healthy and whole. The changes that may happen to their penises, their pectoral or breast areas. I know we're not used to talking about men having breasts, but there may be feelings of shame and embarrassment that may come up where they feel less attractive, less powerful, less masculine. Depression and anxiety are highly prevalent Some studies across that combined samples across over 600,000 men with prostate cancer determined that there were about 6% of those men had depressive disorder of some type. But symptomology was even more widespread in terms of depressive symptoms, from 10 to 40%. Some of the depressive symptoms and even subsequent diagnoses of depression, depressive disorders, are associated with treatment. For instance, if you've gone through androgen deprivation treatment, you have a 23% likelihood of developing depression. Interestingly, when you think about risk factors, you think about older age. That's very prevalent in the literature. That's depression is linked with older age. But if you think about younger men, as my colleague Mr. Morris was younger and in his 40s, when you think about that, depression really can hit you at any age. It's just that you're more likely to have depressive disorders or depressive symptomology as older, unmarried, as you have more comorbidities related to prostate cancer or comorbidities in life in general. Sexual dysfunction has been linked to depression. With anxiety, this is also very prevalent in the prostate cancer population. Anxiety is particularly disruptive as it can increase over time in the prostate cancer continuum, and it's been linked to advanced stage prostate cancer, individual histories of anxiety, lack of family support or other social support. Cancer pain is huge. If you're feeling pain, you may become anxious about what's happening with your disease, your body, your likelihood of survival, etc. And the two of them together are known to increase, to be associated with increased sexual, urinary, and the other physical symptomologies. The bother that one may have related to those conditions. These anxiety and disorder can also push men into making treatment decisions that they may not have otherwise made, which can then play into their ultimate health-related quality of life. There's also this idea of fear of recurrence and progression that go along with anxiety, worry, where even 5 years after treatment, in some studies and longer, men may still have, and it may not be this very conscious thing, but may have this underlying feeling of waiting for the other shoe to drop. This fear that somehow the prostate cancer is going to come back, and if it comes back, it's going to get worse, it's going to progress, etc. So there's this fear of recurrence and progression, but there's also this what we call PSA anxiety, where as men are having their PSAs taken and waiting on the results or even reviewing the results with their providers, there's this situational anxiety that comes up. One of the things we don't like to talk about, and especially within African American communities, is this idea of suicide. There's this myth that Black folk don't kill themselves, and it is just that. It's a myth. What we are seeing in prostate cancer is that prostate cancer patients have higher rates of suicide than even the general cancer patient population. And in fact, roughly 10% of the prostate cancer population has active suicidal ideation, suicidal thoughts. These suicide risk factors, unfortunately, line up with a lot of what we know about prostate cancer. Older age, unmarried tend to have the higher risk. White race is actually associated with higher risk of suicide. Poor physical health, cancer pain, existing or emerging mental health symptoms and disorders. All of these things put men with prostate cancer at risk for suicide. And here's a figure that I shocked me, and I'm hard to shock. There's a study that I found that even more than 15 years after diagnosis, there are men who've been diagnosed with prostate cancer who are still at increased risk of suicide. And, the studies vary, the information varies, but they think it's a combination of long-term physical effects and psychological effects related to prostate cancer, the increase in comorbidities as one ages, in addition to treatment-related and disease-related effects, and possible fear of recurrence or progression that keeps that suicide risk elevated. Predictors of death by suicide include not just older age or aging, advanced disease, unmarried status, etc., but also notice uninsured status. So you've got some social determinants, some social demographic factors that also influence whether someone begins to have suicidal thoughts or begins to plan for suicide. There are a number of interventions that have been floated and tested for helping with mental health, behavioral health symptoms and disorders among folks living with prostate cancer. Chief among those tend to be psychosocial type interventions, talking about psychotherapy, psychoeducation, peer support in terms of their ability to improve health-related quality of life, decrease depression, anxiety, decision-related distress. Some of the data is mixed. Physical activity, some of the data is mixed, but there is a body of evidence also here with physical activity that aerobic and resistance training plus healthy diet can decrease fatigue, physical side effects, improve quality of life, that preoperative Kegels and pelvic floor exercises can decrease urinary incontinence and improve sexual confidence and satisfaction. But then there's some mixed outcomes when it comes to depression and anxiety, symptomology versus disorders. When we talk about significant others, and I use that term very generically on purpose because prostate cancer patients can have male or female significant others. So when we talk about female partners, they may enter the prostate cancer continuum along with the patient with their own physical and mental health challenges. They may have pre-existing chronic conditions, just like their significant others who are the patient, pre-existing mental health concerns. They may also have, depending on the age of the woman, sexual and reproductive health. They may be pregnant or parenting, children of younger age. As a woman, pregnancy is hard on the body. And then the stressors of being a primary caregiver. Menopause for older ladies is real. I can attest to that as well. You may have physical symptoms that vary, mental health symptoms that come along with menopause, mood swings, irritability, difficulty concentrating, etc. And all of these can feed into the changing relationship that they may have with the patient in terms of their own role expectations as they're going through menopause, the norms of their own responsibilities and roles within the relationship, difficulty communicating and negotiating changing sexual and relationship needs, along with their own fear of recurrence and progression and changes in their health-related quality of life. Because remember, prostate cancer is a couple's disease as well. Now, I would be remiss in not talking about folks who identify as LGBTQIA+. As a population, they tend to have more chronic health conditions, poor physical and mental health, individual and institutional barriers to accessing care that result in maybe not having more recent PSA tests. There's heterosexist biases in healthcare settings that can prevent folks from accessing quality prostate cancer care or prostate cancer care at all. 1 in 6 gay and bisexual identified men have a prostate cancer diagnosis. We do not know a lot about trans women. But what we do know is that male and trans women partners experience stressors as caregivers, both commonly held with female partners, but then uniquely and wholly due to being gay or bisexual males or trans women. For instance, psychosocial concerns such as homophobia and being gay, bisexual, trans in America, where typically there is less family or social support. We talk often about the family of heart or the family of choice as opposed to the family of origin, because for many, family of origin support may be lacking. And then partners may have their own history of prostate cancer and how that may impact their urinary, bowel, sexual functioning, etc. Changes in role in sex with the patient. Just briefly about couples, and I know this chart is going to be hard to see and I'm running short on time, but I really want to talk about this concept of simultaneous suffering. Quality of life in couples, particularly prostate couples, is both interrelated and correlated. You know, you cannot really look at just the patient side or just the partner side without considering the whole couple and how their own unique experiences of prostate cancer and other mental health or physical health conditions in the patient and also in the partner may then be magnified within the couple's relationship in terms of their ability to navigate roles, responsibilities, to communicate and negotiate sex and practical support such as transportation, going to appointments, providing real support, even advocating for within healthcare settings and other settings. And so when we talk about mental health in couples in particular, this is where the rubber meets the road in terms of mental health. And because when we talk about prostate cancer, often we assume in healthcare that the primary caregiver is going to be the one that really helps bridge any of the gaps. And yet we aren't supporting these couples or even these families in terms of how the diagnosis of prostate cancer, the lived experience of prostate cancer impacts not just the patient, but their partners and then them as couples and broader as families. So I'm going to really stop there. I can go into this more in Q&A, but my last points to leave with you are we have clearly identified disparities that exist. We have supportive care needs that need to be integrated into prostate cancer care, and yet mental and behavioral health care and treatment remain this undiscovered country that we have a lot of work to do to be able to say we truly provide comprehensive quality care for prostate cancer patients. So I will stop sharing my screen and prepare for Q&A.
All right, can you guys hear me okay?
Yes.
Okay, Dr. Goetz, that was an excellent presentation. Really enjoyed it. And you really hit on one thing about the PSA anxiety. Again, I was diagnosed with it at 41 years old, almost 18 years ago. And I can still say, I call it PSA PTSD. About a year after I had the surgery, I did have a reoccurrence. And I can remember that experience when the doctor came in and said, we're pretty sure, the cancer has spread outside of the prostate and you will have to proceed with the radiation treatment. So even that was, 12 years ago, and I still have that anxiety. I get tested right now once a year. So that's a real true fact that anxiety exists. I want to encourage the participants to ask questions right now. You can put it in the chat and we'll read the question if you have any questions for Dr. Holtz. Mr. Farrington, do you have any questions?
Yes, I am going over the list of questions here.
I had a question, Tom.
Okay, go ahead.
Okay.
Dr.
I noticed you mentioned something about suicide. So just in dealing with many of the patients, there appears to be active suicide versus passive suicide. And that is, passive suicide to me is just like, I'm giving up, forget it. So what are your thoughts about that?
I'm glad you asked that question. I had an earlier slide when I talked about masculinity, self-esteem, and body image. And this is where, masculinity can be particularly problematic in terms of passive suicide, where I'm giving up. And, part of what happens with prostate cancer diagnosis that I've seen with patients, and it's certainly reflected in the literature, is men may compartmentalize. Like they'll pack the prostate cancer in a little box. They don't want to talk about it. They don't want to engage with people. They want to think about it as little as possible. They become very stoic about it, almost dismissive in a way as a self-defense mechanism. But the problem is the anxiety, the depression, the fear can leak through those defense mechanisms in a way that then feeds into this sense of hopelessness and helplessness. And when we talk about masculinity and the way we raise men, the way we norm men in this country, right? The idea that one can't be in control is completely antithetical to how we raise men, particularly Black men, where historically, there's been so much taken away that what can you control, right? Well, here's the situation where you have some things you can control about prostate cancer, but you can't control everything, right? So when this hopelessness and helplessness and this feeling of complete lack of control seeps in, then that is when this passive suicide, there's nothing I can do. I'm just not going to follow up on the test results. I'm not going to go see the providers. I'm just not going to talk about it. No, I don't want treatment. I'm just not going to deal with it. God's will be done. Whatever happens, happens. Right? And then there's this active suicidal thoughts and thinking where you have some of those similar elements, but there also may be very real stressors and pressures, unemployment, underinsurance, not wanting to feel like a burden to one's partner or one's family, and now keep in mind, it is not uncommon for folks diagnosed with cancer and prostate cancer to have what we call non-morbid, morbid non-suicidal ideation. We used to call it death ideation, where it's like, I'd be better off if I didn't have to deal with this pain. I wish it were over. That is actually, especially when you have folks who have moderate to severe pain or a lot of financial or psychosocial stressors, that's not uncommon. But where it tips into active suicidal thoughts is where they're beginning to think about a plan, think about how they would do it, under what circumstances would they do it. Now, even though suicide rates among African American males is trending upward, there's still a protective factor culturally, religious, in terms of, social networks and family support that can happen for Black men with prostate cancer. But I encourage patients to really reach out and talk with their family. Try to not take this all on their shoulders. Communicate with your loved ones and be open to receiving that support. Work with therapists or even your religious leaders about the stigma and the shame. How often do Black men seek mental health services? Unfortunately, not enough. There's a big stigma, especially in Black communities, about mental health concerns. The feeling that, well, historically, nothing could be worse than slavery, so anything that I've got going on can't be that bad. I just need to handle this. That's precisely the time to reach out to family and loved ones and also reach out for help. In fact, I called my dad before this presentation and I said, Dad, what's the advice you can give? What would you want me to say to folks? And he said, reach out early, reach out often. And that includes mental health.
Yeah. And Dr. Goltz, we have a question here, which I also had a similar type question. For a healthy couple that's sexually active, are there any courses or literature that can help guide those couples? Because it's one of the things you do deal with. You prior to prostate cancer, your sexual life was healthy. Now all of certain things change, and most people, either you have to take the oral medication, the injection, or whatever, there are a variety of treatments, and sometimes that creates a little apprehension. I can remember trying to go hide to take the medication, then come back and try to be spontaneous, and then so it took a while for my wife and I to kind of get on the same page.
Mm-hmm.
Any suggestions or any course, any information out there you can recommend to the men out there that have the same issue?
Oh, absolutely. I will say that there are certified sexuality therapists. We're mental health professionals. So, sexuality counselors tend to be medical professionals that deal with sexual issues, and sexuality educators. So the American Association of Sexuality Educators, Counselors, and Therapists has a directory where you can find certified sexuality educators, counselors, and therapists who are certified through ASECT to provide intervention. So there are definitely interventions that can be done. A lot, even couples-based interventions. When I work with couples, some of what I work on is the new normal, changing expectations, changing expectations about spontaneity versus the need for planning. How can we make that playful and spicy and incorporate it into our intimacy building activities? I give them homework, but this is the best kind of homework you'll ever have in your life. These kinds of things to help people to understand that a diagnosis of prostate cancer need not be the death of sex and intimacy. It's just another door that you open, grab your partner's hand, and walk through together. Okay. And so there are interventions available. I'd be happy to kind of forward some information to Finn to provide to folks who attend or even broader Finn community.